Guys, we're in the middle of a pandemic and these are trying times. It's hard on our mental health, our mental state, and this is why I love our sponsor today, BetterHelp. They're the largest online counseling platform worldwide. They change the way people get help with facing life's challenges by providing convenient, discreet, affordable access to licensed therapists. BetterHelp makes professional counseling available anytime, anywhere, through a computer, tablet, or smartphone. It's brilliant. Sign up today. Go to betterhelp.com/solvinghealthcare and get 10% off sign-up fees.
COVID has affected us all, and with all the negativity surrounding it, it's often hard to find the positive. One of the blessings it has given us is the opportunity to build an avenue for creating change, starting right here in our community. Discussing topics that affect us most, such as racism in healthcare, maintaining a positive mindset, creating change, the importance of advocacy, and the many lessons we have all learned from COVID. If you or your organization are interested in speaking engagements, send a message to quadcast99@gmail.com, reach out on Facebook at Quadcast, or online at drkwadwo.ca.
Welcome to Solving Healthcare. I'm Kwadwo Kyeremanteng. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved. Quadcast Nation, listen. We got a boogie changer on the show today, Dr. Wes Ely. Let me tell you, this is a man that has legit helped transform healthcare within critical care. He is revolutionary, and it's a true privilege to have you on the show. Welcome, Dr. Ely.
Thank you, Kwadwo. It's my privilege. And I tell you, this every deep drawn breath title of the book, this has been a project, thinking about it for 10 years, writing it for 3 years, to try and get something in addition to the science to help people understand that we have the capacity to hurt people, or we have the capacity to truly be healers and help them. And what I want us all to do is ask ourselves the hard questions. Are we doing all that we can to bring healing to these people that we come to serve?
Amen. Amen, Wes. And this is exactly what it comes down to, because I can't tell you how many lectures I've given teaching the students, residents about, our role in the intensive care unit is not just to restore life, but it's also to restore function, get people to where they want to be. And this is what was so great about your book, is illustrating how we need to achieve that, how we really, and like how we've almost in some ways lost our way, where the focus needs to be.
Absolutely. One of the best nurses in the book, Marianne Barnes-Daly, said, our job is not just to get these people to survive, it's to get them back to the life that they want to live. And, this whole book, Kwadwo, is full of real people, real names. This is not a memoir. This is a narrative nonfiction book of true human beings, patients, family members, and the scientists who have changed critical care over the past 20 years. And this story is about you, your parents, your mom, your loved ones. It's all of us, because we have on average 2 ICU stays before we die. So it's going to involve every person on the planet, basically, even those in the LMICs, lower middle income countries, where critical care is spreading quickly.
Amen. Amen. And maybe, you're touching on this a bit, but what really motivated the book? There's one thing to publish, there's one thing to, teach, but this is, a unique, writing a book is not unique, but in our profession, this is extremely unique to bust out a publication like this to try and get the word out. So what was the motivator?
Kwadwo, I carried around, I'm gray haired now. You can see I'm 58 years old. I carried around a lot of guilt and a lot of shame for a lot of years, because I went into this to try and give people a voice, to try and make people feel heard. I was a farmer when I was a young boy, and I saw the migrant workers, and they were stuck. Nobody was listening to them. They didn't have a safety net. And I devoted myself to try and help people who don't have enough of a voice. And then as a physician, I saw myself doing things, overly immobilizing people, overly sedating them, separating them from their families. And these things were dehumanizing. And they were not magnifying the human dignity that is innate in every person on the planet. And I thought to myself, this is not okay. So I became a physician scientist, and we've done these large multi-scale, multi-site clinical trials, 2,000, 4,000 people, published them in the New England Journal of Medicine, JAMA, Lancet. But after a while, I realized after 15 years of this, no manner of these papers was going to get the message out to the patients and families that needed this information so they could be autonomous and advocate for one another.
Like basically giving the power back to the family to be able to advocate.
That's right.
So
I want people to keep me honest, Kwadwo. As a doctor, I want them to say to me, Dr. Ely, Dr. Wes, you're not doing your job. My mom is suffering. I'm not there with them in COVID, and you've taken the families away from the bedside. That's anti-medicine. That's anti-healing. And there's nothing right about that. It is outright wrong, and it's an injustice. And we've got to own that and fix it.
I love how you put it though. It is anti-medicine. We are here to heal. We're here to serve. And the thing that's been crazy about COVID is we often are ignoring data. Like, we know how to protect the families and the patients. And I'll be honest with you, there's more detriment, I think, that we did by not allowing families to connect than I could think of. I don't.
Oh, Kwadwo, how many people are? This is crazy to think about this, and we won't know the answer to this question, but how many people are dead in the ground because they lost hope, because the people they love the most that could have stimulated them to desire to live weren't with them, weren't present, and they just lost their way. And when you're delirious in an ICU bed, immobilized, and there's nobody around, think of where your brain goes. Think of where that person's brain goes, all the bad places, all the scary places, and they lose their way. And, it's a beautiful thing when people can find their why to live. Viktor Frankl talked about this in Man's Search for Meaning. After he got out of Auschwitz, he said, if a man has a why to live, he can get by with almost any how. That's a famous Nietzsche quote. But Viktor Frankl said it 4 times in Man's Search for Meaning. But we are letting people lose their why to live, and that is not okay.
It's so well put. We need to help them find their why and take away those barriers. Wes, let's walk through the journey of how far we've come within critical care when it comes to how we used to treat our patients and what the future looks like, or where our goals should be in terms of especially when I'm thinking about is mobilization and sedation and so forth.
Sure. Well, in this book, every deep drawn breath, which, as I said, I call it EDDB. And by the way, I'm not making any money off this book. Every penny from this book is going back to survivors and patients, because I shouldn't make any money off my patient stories. But in this book, I outline that the way that critical care came about was in the 50s and 60s with the polio epidemics. We started with mechanical ventilation, and in the 80s and 90s, we moved ahead with the technology, but we did it with increasing crazy modes of ventilation, like inverse ratio. And when we used inverse ratio ventilation, we started deeply sedating, deeply immobilizing our patients. And imagine it's like an ocean. Instead of keeping somebody right below the surface of the water to keep them comfortable, we're shoving them down with sedatives and paralytics down into the 100-foot range. And we proved with our BIS and EEG data, et cetera, that burst suppression, that is iatrogenic deep sedation, increases death. Okay. And then we built between 2000 and 2010, we built the ABCDEF Bundle, the ABCDEF Bundle. And then between 2010 and 2019, we proved in over 30,000 people. The data are sound, like you said. We know what works. We proved in over 30,000 people that if you can get 70 to 80% compliance with this A2F bundle, which is like a safety checklist of 6 steps.
You want to just go through them real quick?
Throw it out? Yeah. A is analgesia, make sure people aren't in pain. B is both SATs and SBTs, which that's spontaneous awakening trials and spontaneous breathing trials. All it means is waking people up and turning off the vent to see if they still need it. And if you're guessing whether or not they need it, you're going to get it wrong half the time.
Mm-hmm.
So you've got to turn the drugs off and turn the vent off to tell. And that was my first big paper in the New England Journal of Medicine in 1996, where we made popular spontaneous breathing trials. And then J.P. Kress in 2000 in the New England Journal as well made popular spontaneous awakening trials. So that's the B. C is choice of drug. That's avoiding benzos. And during COVID, benzos came back. We had gotten rid of them prior to COVID. D is delirium management. And we ask people to just check if they're delirious, use the CAM ICU, or in Canada, it's popular to use the delirium screening checklist by Joanna Skrovic from from Montreal. And if they're delirious, follow the Dr. Dre, diseases, drug removal, environment, D, DRE. And then E and F is early mobility and family. So that's what it is. Analgesia, both SATs, SPTs, choice of drug, avoiding benzos, D, delirium, E, early mobility, and F, family. And we showed that if you can get 70 to 80% compliance, we showed around the world that you will reduce death, reduce length of stay, reduce bounce backs to the ICU. You're going to also have more home transfers rather than nursing home transfers, and less delirium and coma. So it's a humanizing safety bundle, basically. And pre-COVID, we were up to 70, 80% around the world. We published this in intensive care medicine. And post-COVID now, we just published a point prevalence study. We're down in the 10 to 20% range, Kwadwo. So it's all falling down, and we've got to build it back.
100%. And people, I want to put the point of emphasis that within our world in critical care, there's very few interventions that have shown to improve your mortality or outcomes that you care about. Okay. So when we got something like this, legit, the ABCDEF bundle, something like this, that we know is effective, there's no way we can't be ignoring that. There's no way we can't be striving for excellence when it comes to this.
I love it. I love your energy. My fellows that have trained with us, they were down in New Orleans. A lot of them left. I'm in Nashville, Tennessee at Vanderbilt University. And our website, by the way, is ICUdelirium.org. So people just Google ICU Delirium. You'll find us at ICUdelirium.org. Tons of stuff on that website for you for free, educational, et cetera. But our fellows went from Vanderbilt down to New Orleans and called me and said, Wes, we are crazy down here. We have thrown out everything we know, and people are dying because of it, and we're going to get back to the basics. And they have subsequently gone back and just re-implemented and changed their culture. And they sent me a picture recently of a woman in COVID on the vent on 100% FiO2, P 16, wide awake, looking at the camera with a pad in her hand saying, "Get the damn vax," to her family. So, we know what works. We can do this, and it is appropriate and humane to do it. We just have to change our culture, Kwadwo.
Yeah, and Wes, I agree, and it takes effort. Let's not beat around the bush. This is to do these things. It's effortful, and the point here though is that it pays off in dividends. And one other point too, Wes, is that we should touch on too is the mental impact that having this approach has on our patients. Like the amount of PTSD, depression, anxiety that comes from our patients when they leave us, and is directly correlated to how deep their sedation is, by the way, and how immobile they are. Like this could be profound on people's quality of life. It
really is. I love your point. Yesterday I was in the COVID unit. We admitted 5 new ones yesterday, and one of the guys was a songwriter, beautiful guy, amazing person. And I said, "Sir, what matters to you?" Instead of saying, "Here's what's the matter with you," I changed that preposition, "what matters to you." He said, "I love music." And I said, "Well, listen, that's great. We can get back to music, but I've got to get you out of this bed." And he goes, "I'm too depressed." I said, "How about some Elvis?" So I put on Elvis Christmas song, and he stood up and danced a jig with the high flow nasal cannula on him. And then he got in the chair and he was super exhausted and breathing hard to Kipnick, and his sats were in the mid 80s, but that's okay. Hey, he's moving, his body's working. And that's what we need, is to motivate people with what matters to them, Kwadwo.
Exactly. Find what is their why, as you said. What's going to drive them to for betterment. And I love that question, Wes. I might rip that one off and teach the kids that one too. But on the other end too, I remember in the book talking about a guy with necrotizing fasciitis. I'm trying to forget.
Kyle Mullican.
What's his name?
Well, there was one guy, a woman had necrotizing fasciitis on her face, and another guy had pancreatitis. And that woman, I said to her, I whispered to her every day, she was an ARDS. Her name is Janet Keefe. All these people gave permission to use their stories, and all their pictures are on the internet. If you go to ICUdelirium.org, there's a photo gallery where you can see all these people's pictures. It's really great. Mm-hmm. But I said to her every day, Janet, you are a refined badass. And I said it because there was a picture of her in front of the Eiffel Tower. And I said, you're a refined badass. Now you get yourself out of this damn bed. And when she finally woke up, she was in a coma, sedated deep at the time, because she was really disintegrated with a ventilator. And then when she woke up, she said, Dr. Ely, I heard you telling me I was a refined badass, and that saved my life. So 2 points in that. Tell people what you need them to hear, one. And two is, yes, at the beginning of their time, you might need 12 hours of deep sedation. You might need transient, paralytics. But do not think that what you need on Monday is what you need on Tuesday. Every time that sun comes up, it's a new game, baby. You got to turn the stuff off and force yourself to give a hard ask. Is what I did yesterday still helping now, or is it now hurting?
Oh, I love it. It's so true. Tomorrow is a new day. This is a new, what happened yesterday doesn't necessarily have to be true today. And so to progress, move forward, to inspire, to get people moving. This is why I always say, one of the most underrated people in ICU is our physiotherapists. Like, if I were in charge of an ICU, well, I guess I technically am, but I would be flooding them with physios, getting our patients.
You got it. Listen, for all the listeners, because a lot of these people are young on your podcast, I bet you, in 2006 to 2008, we studied stopping sedation, and we published this in the Lancet. It's called the ABC study. That was the beginning of our ABCDEF bundle, but it was just the ABCs then. And get this, we turned off sedation in half the patients every day. The nurses said, it isn't working, Dr. West, Dr. Ely. It's not working. I said, why not? And they said, well, we always have to turn it back up. And they were remembering, 1 out of every 15 people. But the other 14, they didn't have to turn it back on. And at the end of the day, we had, by this protocol, cut propofol in half, cut benzos in half, and cut morphine in half, and fentanyl in half. And when we did that, at the end of 1 year, instead of dying 45% of the time, these rip-roaring sick sepsis patients died only 30% of the time. We had a 15% absolute risk reduction in death. That is one of the largest survival advantages ever proven in all of critical care. And it was just by turning sedation off.
Oh, man, there's so much. I don't want to get into the weeds too much because our audience is pretty, like healthcare providers, not just critical care. But the fact even that I've been telling our researchers, we need to do more bundled research projects. To think that one intervention on its own is going to show this, as you were able to do, a 15% absolute mortality benefit, it's a pipe dream with so many of the studies that we're doing. But man, it's pretty spectacular.
And since your podcast listenership is broad, I want them all to hear me say this. This topic involves you. It involves all of us, because if you're well, but your loved one's sick and they're in the ICU, you have to become their advocate. And I just published a piece in the Daily Beast. You can look it up, Wes Ely, the Daily Beast. And it's on what you need to know to advocate for your loved one on their next ICU stay. Because when you come in there and you start asking us hard questions, not being rude, but just saying, look, I'm aware of the ABCDEF bundle. Are we doing this for my wife, for my husband, my brother? And you will keep us honest, and you will push us to do a better job for your loved one. And we need that. And one more thing, Kwadwo, this is not just humane for the patients and families. It's also humane for us as healthcare providers, because this is an anti-burnout program. We are less likely to burn out and much more likely to find meaning and satisfaction in what we're doing if we know that we're doing the right thing. And we know that we're hurting people when we treat them the way we have in COVID. It wasn't right. It isn't right. And we're suffering existential harm and moral injury because of this. And that's why people are leaving medicine. It's sad.
I think this is a very underrated point, Wes, about the burnout. And as you said, when we saw this 20 months, 20 plus months, I'm timestamped this is December 16th, we're doing this interview. The component of burnout is heavily related to what we saw dealing with COVID patients. As we talked about, having people separated from their families. We took patients, Wes, that were over 4-hour drive, I can try to think in miles, 250 miles away from their loved ones, with the ongoing restrictions for visitors too. And so this was traumatic for everyone. And the point you make, though, about how reinvigorating it is when we see people get better, like truly better, like they get extubated and they're still delirious. Like, yes, it's nice they're extubated, but it's still you see the distress in the family when their loved ones, is not who they are at the time. But when you see them truly get better, there was, I had a patient. Very few times I well up when we're in the ICU, but there was a patient that had been there for months, and we didn't think she would have a chance with her COVID. But she turned around, trached, and when she was getting wheeled out of the unit, we started clapping, and and she was welling up. I couldn't help it. I got a little verklempt. I'm getting verklempt just thinking about it, actually. And
you should, because when we keep ourselves at arm's distance from these people, we're not only not entering into their chaos, we're also preventing ourselves from that true richness and the beauty of medicine. Osler talks about equanimitas, and equanimitas means equanimity, keeping an even keel. I overused that tool greatly when I was a young physician. I don't want to live like that anymore as a doctor. I don't want to. I want to enact what I call my working definition of mercy. And that is, mercy is the willingness of me to dive in to the chaos of another person's life and provide lifting and healing. And that second part is important, because we dive into their chaos all the time, putting in a central line, intubating, that's diving into chaos. But are we providing the full lifting and healing that we need as physicians and as ICU, as anybody in the healthcare profession, if we don't really just meet them where they are, kneel down, hold their hand, look at them in the eyes and say, I care about all of you, not just your matter, M-A-T-T-E-R, not just your physical substance, but I care about your mind. I care about your spirit. And I want to walk with you, and I'm not going to leave you. I will not abandon you. And even into survivorship, you mentioned this person leaving and you welling up, and we are setting up all these survivorship clinics now, and we're watching these COVID patients go into their long COVID journey and long hauler journey, and I want to be with them. I go to their houses, I call them back, and they come. We have survivor support groups here at our center. We have our center is called the CIBS Center, CIBS, Critical Illness, Brain Dysfunction, and Survivorship. And that S is important, that survivorship. I mean, our job is not done when they leave the unit. We have to help them rebuild their lives. And that's really the whole point of every deep drawn breath, EDDB, is that we have a lot of work to do for these people, millions of people in the upcoming years, to help them pick up the pieces of their life. That's why every penny is going back into an endowment to help them. And we're going to make that help for Canadians and for Americans and for people in any country. They're going to be able to connect with our CIB Center, and we're going to provide them services.
That's honestly, it's incredible. It really is incredible, because, I find with our job, we often ask ourselves, are we just, sometimes there's this attitude that's like, we're just delaying death for some patients or whatever. But, there are the patients that could get back to where they are, close to where they were before. And if we could have the tools and the the energy and the focus to do that, like, absolutely, we need to be doing this, Wes. And I got to say, when it comes to what you said too, I forgot the term you used, to connecting with your patients. It was a unique one. It's going to come back to me in a second.
Okay.
Mastery? Anyways, it began with an M. It's funny because, as you said, when we're upstarts, you kind of try not to get too involved or like too engaged in the patient. So, because you want to be able to stay like if you get too emotionally involved, then a lot of people feel like you can't be objective in your decision making, and it's just
equanimity.
Equanimity. Yeah, thank you.
Yeah.
But I'll tell you, this is something that has been so fulfilling as a physician. Like, this is probably why I did the palliative care side too, is when you make that connection. Yeah, and there's bad results, like the patients pass away and so forth, but it makes the job meaningful. It really does, and I highly encourage.
But let's talk about two things related to end of life. Deborah Cook is a very famous Canadian.
Oh yeah, we know Deb. Don't worry.
I know you know Deborah.
Yeah.
Well, she's all in this book, as you know, and there's a huge section in this about her 3 Wishes project, and that's we initially think, and your listeners might initially think of death as bad, but we all are going to die, and if we're going to die in the unit or peri-critical illness, then we have to be ready to say, you know what? That death is coming. We're going to make that not a bad thing. We're going to make it a good dying process. We're going to love that person, provide them that mercy, and we can do it beautifully. We can provide that palliative care, primary palliative care in the ICU, and really make sure that the person is lifted up, that their dignity is upheld, and that we pay attention to what matters to them. And there's all kinds of stories in EDDB about how we do that with dogs in their beds. And, a mailman overcame fear of dogs, and we brought a dog in his bed, and his heart rate was 140 for 3 days in a row. We put Bacchus, the god of wine, in his bed, and his heart rate was down in the 70s in a matter of 20 minutes. And we did nothing else to him but put that dog in that bed. And these are the beautiful things that we have available to us when we keep our eyes open and when we insist on providing love. Avidus Donabadian, this wonderful quality improvement guru who started QI, said the secret to quality is love.
Wow.
And if we just bring that love, we're going to find the right way forward. And it's not easy, as you said. It takes a lot of work, but it's worth it.
It is 100% worth it. I really like that. I don't know if I've heard that the ticket be in love, but I would be remiss to ask you, like, how do you create the culture? Like, how do you create the change? Because there's so many staff that are set in their ways, and I want to give you a tool. Here's the tool. Remember this phrase: "What can I do by Tuesday?" And I didn't invent that tool. That's the IHI, the Institute for Healthcare Improvement, the largest QI program in the United States. But what can I do by Tuesday? So you're in there on Monday and you say, we want to change this culture. Well, we can't change it all at once because culture is hard. But what I can do by Tuesday is I can go find one nurse and one patient. And tomorrow morning, we'll set up a time at 9 a.m. or whatever, and we're going to go to the bedside and we're going to do the ABCDEF bundle on just one nurse and one patient. And we're going to see what works. And we're going to talk about what doesn't work. And we're going to wake them up, cover the analgesia, do the SAT, SPT. We're going to switch them off of benzos. We're going to get them out of the bed. We're going to do the Dr. Dre for delirium, and we're going to get their family involved. And then we go back on Wednesday, same patient, same nurse, and do it better. And then we go back on Thursday and do it better. And that's PDSA, Plan, Do, Study, Act cycles, iterative cycles of quality improvement. Baby steps, little hills, not mountains. And then the next Tuesday, we do a different nurse and a different patient. And week by week, we take one nurse and one patient at a time, these individual PDSA cycles, and you watch yourself go through January and then February and then March. And several months into it, other nurses who never wanted it before and said, no, I'm good. I like the way I do it with deep sedation. I like my sheet to be tight. I like the bed to look pretty. And the other nurses' beds are all messed up because somebody's woken up and they're messing the bed up. And the nurse is like, maybe that tight sheet, that pretty bed isn't so worth it. I see what's happening over there. They're walking Mr. Smith over there.
I want to be a part of that. So little by little, people start wanting to be a part of this. They want that action. And that's how you change the culture. You do not do it by saying on April 1st, we're going to all start doing the bundle. It never works that way. Loserville. So it's what can I do by Tuesday? PDSA cycles, start slow, start small, and go for that.
Do you know what I love about it? It just makes so much freaking sense. Do you know what I mean? It's baby steps. It's truly, because it's, as you said, if it comes from above and you say, yo, this is what we're doing now from forevermore.
Won't work.
Yeah. People get the nuts in a, is that
Guess
an expression?
what? Nobody likes to be told what to do. Nobody. Yeah. Anytime I push anybody, I realize it doesn't work.
Yeah.
You have to allow them to come to that. And what you've got is early adopters and late adopters. And neither of them are bad. You know, the late adopters are very important. They have institutional memory. They remember when we tried things and they failed, and they're going to keep us honest. So they're all important. But do the early PDSA cycles with your early adopters, and then watch the late adopters help calibrate you over time. And don't be in a hurry. You know, we're going to do this. We're going to do it over time, and we're going to make a lasting change. If COVID hadn't been such a tsunami, it wouldn't have been able to take this down, because we built it carefully. We built it over years, and we did it well. But COVID was such a crazy thing. No PPE, fear of contagion, no vaccinations, that it took it down. But we're going to build it all the way back and stronger, because we have the data. And this time we're not starting from scratch.
So well put. So well put, Wes. I'm just so impressed, I must say, just the energy, the passion, and like, there's one thing to just walk or talk the talk, but you walked it. You freaking marathon this bad boy, man.
Well, I'm not going to give up on this. I thought I was kind of done. I was writing the book to give it to people and say, look, this is how you can do it where I'm not. But and this wasn't all me. I mean, it was a lot of people, but I was kind of handing the bundle off. But now I realize, you know what? For the next 5 years, I'm going to work with all these other people all over again. And I do not want to take credit for this, because so many people are part of this. Mm-hmm. The SCCM's ICU Liberation Group Collaborative has great leadership. It's a beautiful organization. And the ABCDEF Bundle is now the formal way that the largest critical care society in the world has said they want to do QI. Yeah. And that is the Society of Critical Care Medicine. And whether it's India or London, England or Thailand or all of Latin American countries, we're going to do this throughout the world. And I don't want to leave out the LMICs, the lower middle income countries. They have to be involved. I work with Partners in Health down in Haiti to try and get critical care down in Haiti. And we've been working in Zambia. We're now doing trials in Rwanda and Kenya. And it's just, we all are involved in this. We're all brothers and sisters. And it's a butterfly. When that butterfly wing flaps, that is going to be felt all across the world. So everybody, let's get involved. Let's do this for each other, you know?
Wes throwing down. I feel like you could be a preacher as well, my friend. Maybe we can end off with any stories that come to mind from the book that were your favorite, in terms of, illustrating either the importance of getting our personalizing patients, or just somebody that you connect with.
I'm glad you asked that. There's a lot of social justice in every deep drawn breath. There's about 30 different excerpts of things that we do that are parts of epistemic injustice. Episteme means knowledge. And so epistemic injustice was when we hold knowledge that we don't give to our patients and families, and that's wrong. Testimonial injustice is a form of silencing others. So here's a story from EDDB that has a bit of both. There was a man named Jimmy Johnson, and he was my patient. It was during COVID. Jimmy was an inmate. He came in, he was an ARDS, intubated, and he was not allowed visitors, and he was cuffed to the bed. And I saw Mr. Johnson on that morning with that big red cuff, and you can see the pictures of the cuff on our website. Go to ICUdelirium.org and hit the EDDB page and go to the gallery. You can see these pictures. And anyway, Jimmy, I said to the team, why does he have cuffs on? The guy is intubated. He can't hurt anybody. And so they were like, I don't know. And I said to the guard, take those cuffs off him. And they said, we are instructed to keep number 572389 in chains. That's what they said. And I was livid. So and I'm no hero here, because many times earlier in my career, I've left those cuffs on thinking it's the rule. But now after writing EDDB, I was like, you know what? I can't live like that anymore. And so I wrote an order to the prison warden and guards. And I said, I am the doctor, and I'm telling you that my medical prescription is you have to remove the cuffs. And within an hour, those cuffs were off of that patient. And Mr. Johnson lifts his knees up in bed. He looks over at me, nods, intubated. And there was so much he said with his eyes to me. And then the next day we extubated this guy, and I thought he was for sure dying. We were switching, you're a palliativist. So we were switching our ladder that we were climbing from cure to comfort. And I was sure he was dying. I mean, as sure as I've ever been. And we started talking. He was telling me stories. He was telling me when I was little, I used to ride horses. I was always late for dinner. My mom would get mad at me. And we just shared these stories and started talking about his life. And then a medical student worked to get his sister there. The prison had to override a no visitation policy for the prisoner. And his sister, Johnny Blackwell, that was her name, came in. So Johnny is talking to Jimmy, a woman and a man, and they're just sharing stories. She was telling me when Jimmy got his first car at 17, he took off. We basically didn't see him anymore, Dr. West. And he had his first daughter within a year. She was born on April Fool's Day. Her name was Shatika. And they were laughing and giggling. And you know, he is still alive. He did not die, because that gave him his why to live back again. And that is medicine. And nothing that I did, antibiotics or ventilator management, none of that is what saved his life. It was being with his sister and being showed human dignity. And that's what EDDB is all about. And I hope everybody listening joins in, gets this book, leave your reviews on Amazon and Goodreads to get people involved in this story. And let's do this for other people.
Wow. If that is not motivating, Kwadcast Nation, I don't know what is. Dr. Ely, thank you so much for agreeing to do this. It's meant the world to us. And I'll tell you, selfishly, I am mad inspired right now to change that boogie within the critical care. So thank you so much.
Let's do it together. Thank you, everybody. I appreciate you.